Hereby I open this academic ceremony in which Mohammed Ali Alahmari will defend the academic thesis Radiological and Radiotherapeutic Nuances in Skull-Based Tumors, a focus on efficacy and safety in chordoma and vestibular schwannoma. May I invite you in the next 15 minutes to present a summary of your study and the conclusions of your thesis.
Thank you. Dear Pro-Rector, members of the Corona, supervisors, family, and friends. In the next 15 minutes, I will present my PhD research entitled Radiological and Radiotherapeutic Nuances in Skull-Based Tumors, a focus on efficacy and safety in chordoma and vestibular schwannoma. I'm going to divide my talk into 3 parts. First, short introduction, and then I will briefly present the results of my work, and finally, I will provide you with the main conclusions. So let's begin with a short introduction. So why skull-based chordoma and vestibular schwannoma and not other tumors? I chose skull-based chordoma and vestibular schwannoma as they are challenging skull-based tumors, and the evidence of the available treatment choices is still weak. This diagram is to show where the skull-based chordoma and vestibular schwannoma can be found within the skull base. If we take an axial slice of the skull base, this is how it will look like. Skull-based chordoma and vestibular schwannoma are both tumors that can grow in the posterior fossa of the skull base. Here in the clivus bone is the location of skull-based chordoma, and here in the cerebellopontine angle is the frequent location of vestibular schwannoma. Both locations are considered very critical. Why? Because first, they are located deep in the brain. Second, they are adjacent to sensitive structures in the brain, like the brainstem, major arteries and veins, cochlea, and neuronal structures such as the optic chiasm and the facial nerve. An increase in the tumor size means more involvement of these sensitive structures, and therefore increases the challenge of surgery and the planning of radiotherapy. With regards to the differences between the 2 tumors, here are some of them. Skull-based chordoma is malignant, originates from the embryonic notochord, very rare, affects 1 in a million, and infiltrates in all types of neighboring tissues without predilection. So at times, it's not easy to identify its boundaries on the MR images. By contrast, vestibular schwannoma is benign, originates from the Schwann cells of the vestibular cranial nerve, represents around 10% of all intracranial tumors, and it is easy to identify on the MR images. These different natures highlight the degree of difficulty during treatment, with skull-based chordoma being more challenging. Now, turning to the results of my work. One aim of my thesis was to assess the safety and efficacy of proton therapy in patients with skull-based chordoma and identify radiological patterns of recurrence after treatment failure. The recommended treatment for patients with skull-based chordoma is a total resection of the tumor. However, a total resection or a complete removal of the tumor is usually not achievable in skull-based chordoma, and chordoma cells are known to have high ability to survive. Therefore, it is recommended to apply a high dose of fractionated proton therapy of at least 74 gray over the pre-surgical tumor bed with a marginal dose. We conducted a systematic review to obtain better understanding of this treatment approach and found that despite the use of high doses of proton therapy after surgery, recurrence rate in skull-based chordoma remain high. Recurrence is expected to occur by around 26% within 3 years after the treatment. Moreover, significant number of patients experienced different grades of radiation side effects after proton therapy, ranging from grade 1 to grade 5. Grade 1 is very mild side effects, and grade 5 is death. The systematic review served as a background prior to the analysis of our cohort. After searching the database of Maastricht University Medical Center, we found 16 patients who had skull-based chordoma and were treated by surgery and high doses of proton therapy. Of these 16 patients, 7 developed recurrences. We evaluated these 7 cases, aiming to find a radiological pattern of recurrence, understanding the image characteristics and the behavior of recurrent chordoma can help clinicians to provide patients with the best and safest treatment choices. The evaluation was conducted using the MRI images of the follow-up and those used to plan the delivery of proton therapy, plus medical reports. The correlation between the location of the recurrent chordoma and both the surgical trajectory and proton therapy corridors were taken into account. So before presenting our results, this figure is just to remind you the primary location of skull-based chordoma. After evaluating the MR images and the medical reports of our patients, a number of 18 recurrences were identified in the 7 patients. This figure shows the locations of all the new tumors in relation to the location of the primary chordoma. Almost all recurrences occurred in adjacent location, separate from the primary chordoma and outside the therapeutic radiation areas. And this figure is an example of a real T2 MR image for one patient who developed a subcutaneous recurrence just under the scar of surgery. In literature, recurrence in the surgical pathway was described at max in 7.3 of the cases. However, our study showed that 32% of our patients has developed recurrences in the surgical pathway. This finding may be considered as a warning that this type of recurrence remain underexposed and the recurrence rates in the surgical pathway in literature could be higher. Another finding of our study, different grades of radiation side effects were observed among our patients, with the most serious form being radiation necrosis. This finding is in line with the literature and almost similar to those reported after photon irradiation. Radiation necrosis is sometimes difficult to distinguish from tumor progression and may cause a delay in taking the proper intervention. Another aim of my thesis was to evaluate the safety and efficacy of a slow trending treatment approach for patients with large vestibular schwannoma. A complete resection of a large vestibular schwannoma has been a recommended treatment approach for years. That is mainly due to the excellent control rates as reported in many publications. However, as the facial nerve is normally stretched by the large size of the tumor, a facial nerve dysfunction after complete resection is relatively high. Therefore, to avoid injuring the facial nerve that may result with complete resection, some researchers suggested partially resecting the tumor until a brain stem decompression is achieved and leaving some of the tumor tissue around the facial nerve. To stop or control the remaining tumor from regrowing, it is recommended to apply a radiation dose of 12 to 13 gray to the remaining tumor within 6 months after surgery. We evaluated the safety and efficacy of this combined approach in 25 patients, and the evaluation was based on the tumor control, facial nerve function, radiation side effects, and surgical complications. How? We used 4 MRI scans for each patient to evaluate changes in the tumor volume and report any radiation side effects. All volumes were carefully measured in 3 dimensions using the 3D slicer software. The medical reports were also checked to collect data related to the facial nerve outcomes and surgical complications. After a median follow-up of 37 months, we achieved a tumor control in 22 patients. All patients enjoyed a normal function of the facial nerve. No surgical complications were observed among our patients. Only 1 patient developed a lower grade of trigeminal paresthesia after radiation therapy. When we compare our results with those reported after complete resection, we can say that we achieved almost similar control rate. We can say that we achieved much better preservation of the facial nerve, and the surgical complications were found more after complete resection in literature. In my thesis, I also looked into an imaging challenge related to the vestibular schwannoma management. A part of my work was to propose the best imaging sequence to visualize the facial nerve using the MR diffusion-weighted imaging. Determining the facial nerve course before vestibular schwannoma surgery is important to preserve the nerve during surgery. Since 2006, researchers started to report the clinical feasibility of the diffusion-weighted imaging in identifying the facial nerve course around vestibular schwannoma. However, all of the previous research were showing the facial nerve in combination with the vestibular cochlear nerve and failed to show a separate depiction of each of the 2 nerves. By optimizing one of the diffusion-weighted imaging sequences described in previous literature, we were able to show each of the 2 nerves bilaterally. We acquired the raw data images using a 3 Tesla MRI scanner, and after following several steps in image analysis, we could successfully show each of the 2 nerves bilaterally. This figure shows the facial nerve in gold color, clearly separated from the vestibular cochlear nerve turquoise color. That's complete my overview, and now I will sum up the main conclusions. First, anatomical distortion after surgery is the main prognostic factor for treatment failure on skull-based chordoma. It increases the interval of adjuvant radiation therapy, relocates tumor cells from one side to another, and delays the diagnosis in the case of recurrence. Second, with respect to the reduction in radiation-induced effects, it seems hard to prove the superiority of proton therapy over photon-based radiation therapy in the presence of high prescribed doses. Third, to treat large vestibular schwannoma, a partial resection followed by 12 to 13 gray doses of gamma knife is an effective strategy to preserve facial nerve function and control the residual vestibular schwannoma with minimal surgical and radiosurgical morbidities. And finally, conventional diffusion-weighted imaging is able to show a distinctive visualization of the facial nerve from the vestibular cochlear nerve. Thanks for your attention, and now I'll bring back the words to the prorector.
Thank you for the presentation. Well in time and very nice presentation. The opposition now will be started and be opened by Professor Kunst. He is skull-based. He's from the Department of Skull-Based Pathology and Maastricht University. He's online.
Thank you very much for the kind introduction. And thank you, candidate, for presenting, and congratulations with finishing this thesis. It was a pleasure to read the various chapters. First, I would like to start to kick off with a question on chapter 4. And this is on page 78. And that's the chapter also on NF2 vestibular schwannomas. In the paragraph 5, the first lines, you state that radiotherapy in NF2 patients is less effective than in the regular vestibular schwannomas. Then below, in the same paragraph, you mentioned some figures, percentages of tumor control. And I was wondering, because the references mentioned at the first line, that it is less effective, they are quite old. Then below in the same paragraph, you have other reference. But if you have a look at the percentages, could you point out why you conclude that it's less effective in NF2 vestibular schwannomas?
Highly esteemed opponent, thanks for your congrats and your questions. Actually, to best answer your question is due to the nature of NF2 is totally, I think it's different than the sporadic vestibular schwannoma. So at times it's not responding as the sporadic vestibular schwannoma. So most of the research that I came across, when they analyzed the data about NF2, they separated both as they are different in nature. So that's why it's less effective, and surgery is the first choice to treat this type of tumor.
But to be more exact, if I have a look at the paragraph that you wrote, then for example, Mathieu, you write that you have after even 15 years, an 81% of tumor control. And then there are some other references below that states 66%, 5 years. Then another reference, 5 years, 75% the tumor control. And would you conclude then with those percentages that it is lower tumor control than in a regular vestibular schwannomas?
With NF2?
Yeah, for NF2.
No, I would say that it can control the tumor, but for the preservation of the functional for the functions, it's not as the sporadic vestibular schwannoma. So it can work with some patients, but will be the gold standard for this type of tumor is surgery at first. But for some patients who doesn't like surgery, this can be choice for this type of tumor.
Because I must say, if I have a look at the plain figures that you wrote down yourself, then I think, for example, the 80% 5 years tumor control, and then below 70 and 75, they are quite okay. And moreover, I'm missing that reference is missing out. And in 2018, Kruid et al., they wrote an article also on gamma knife therapy and the results. If you leave out the Wishart type, so the more aggressive NF2 type 2 patients, then also in that series of about 50 tumors, the same tumor control rate as in the regular vestibular schwannomas was found. And actually, your figures, the things that you wrote down here, they are not too bad also. So I can imagine that you can argue what the best treatment choice would be. Why am I focusing, do you think, on this? Because if you would operate, you will damage for sure the 8th cranial nerve. You have a bilateral deaf patient often. What would be the result if you operate on a bilateral deaf patient and you damage the 8th cranial nerve? maybe even on both sides after operating? What would be the consequence for the patient?
The consequences after death, after the cause of the death, after operation?
Yeah, if you operate and you damage the cranial nerve, the number 8, so the hearing nerve, on both sides, what would be the consequence for the patients?
It will affect the quality of his life.
Yeah, and in what way?
In what way?
Yeah.
So it will impair him from practicing his daily life as normal people. So for a patient who to serve his functional, if he has pre-surgical hearing, so it would be better to apply radiation therapy instead of surgery. If the risk of surgery is higher to lose the hearing function, so we would go for the radiotherapy in this case.
I think it's indeed very important in NF2 patients that often you have a bilateral hearing impaired patient, maybe even deaf patient. And also what I'm trying to say, so that is a good answer that you say, well, for preserving hearing, then a radiotherapy would be better. But also if you have already a deaf patient, if you transect the 8th cranial nerve, you can't put in anymore a cochlear implant. And with a cochlear implant, you can rehabilitate also the patient in NF2 patients. So that's also something to keep in mind.
Thank you.
Yeah. I'm looking at the time. Is there still room for a second question, or should I finish?
A very short question and a very short answer, please.
I keep it very short. Then chapter 5, you have a very nice under page 105, chapter 3.2, you have a tumor control rate of 88%. But if I read it well, also the bigger tumors that were not in follow-up, they are also a part of this 88% tumor control rate. So also probably tumors were in between there that were non-growing tumors. And then my question would be, if you operate a big tumor, maybe even a non-growing big tumor because you have brain compression, why would you irradiate then straight away? Why not wait and scan? Because maybe it's a non-growing tumor.
Yes, I agree with you. For young patients, it is recommended to wait and not to irradiate the tumor immediately after the surgery or within 6 months after the surgery. But if the case is needed for radiation therapy, this would be a practical or a good practice to irradiate the tumor to stop the regrowing. But for some cases, why not? We can wait and scan the patient and not irradiate the patient and expose him to radiation. Yes, I agree with you.
Okay, thank you very much. Thank you very much.
You're welcome.
Okay, the opposition will be continued by Dr. Paiva Fonseca, Assistant Professor at Maastricht Clinic.
So first of all, I'd like to congratulate you and your promotion team for the nice thesis. And my questions are mostly related to the treatment planning system. So for example, in the chapter 3, you mentioned that you could increase the volume, the target volume, or increase the dose in certain regions to reduce recurrence. Can you expand a little bit on what would be the approach you would follow to reduce recurrence regarding the treatment planning system?
Esteemed opponent, thank you for your compliments and question. So you are asking about what kind of approach or what kind of approach that we can use to stop recurrence.
Yeah, so you mentioned that you could, for example, increase the volume. So I'm wondering if you're suggesting that you increase the margins or increase the dose to the target. What would be your approach to reduce recurrence regarding the TPS?
increasing the volume and increasing the dose always with skull-based chordoma is very limited due to the organ at risk. So we have to take care of this. So skull-based chordoma is normally adjacent to these sensitive structures, and the planning should be taken in a multidisciplinary way. So it might be feasible to use like one of the strategies which is called integrated or simultaneous integrated boost of radiotherapy. So it might work with some patients. Yes.
Okay, so I think then you have the balance between recurrence and the side effects.
Sure.
So it also leads then, I think, to your chapter 7, where you made a comparison between two algorithms for the treatment planning system. Could you elaborate a little bit more on the reasoning of this comparison, and also what are your main conclusions there?
Yeah, I would say, to answer this question, that those calculation algorithms is mainly the purpose of these algorithms is to precisely calculate the distribution of the dose to the clinical target volumes and the surrounding sensitive structures. I mean the low dose areas. So it should be precise enough to spare these sensitive structures from overdose. So it's very important to have like such precise calculation algorithm, because the normal tissue, the effect on normal tissue is normally steeper than the tumor tissue. So we should be careful and avoid unnecessarily like radiation side effects that may result from planning.
And you compared the AAA and Acurus, right?
Yes.
Did you expect a difference between them?
According to our results, we couldn't find like a significant difference between the two algorithms. So based on these results, we can use them in the clinic and continue to distribute or to calculate the distribution in the normal, in the low dose areas.
Okay, so you mentioned that the both codes, they agree then, but is it possible that they're both wrong?
Yeah, it might be. So nothing 100% sure, especially in the dose planning algorithms. Even Monte Carlo simulation, still there is uncertainty level. So, and it is acceptable by the International Commission of Measurement and Units to that there is maximum 5% of uncertainty. So up to 5%, I think it's acceptable level.
Okay, and you mentioned that you didn't find much difference for these different algorithms, and you compared 10 patients. What was the criteria to define 10 patients?
The criteria included, all of them have like neurological tumors located in the brain, and all of them treated with the linear accelerators. And we could like calculate or recalculate the dose again using the both systems, both algorithms.
Okay. Did you have more patients and stopped after 10 because you didn't see any difference, or 10 was the number of patients that you had available?
No, actually that is the number, and we think that is enough to conclude whether they agree or not.
Okay, and I have just a final question about this then, because in your study you compare protons, you compare gamma knife, photons, linacs. So why, when you go for the TPS, you decide to study the VMAT, linac, and not protons? What's your reasoning, your decision to go towards the Acurus and AAA and not protons?
Protons actually is, will involve more like sophisticated like algorithms, and it should, I think, include Monte Carlo simulation. And almost, I think they are using Monte Carlo simulation in Maastricht clinic. And I think at the time of conducting the study, it was at the early stage of proton therapy in Maastricht clinic. So that's why we chose these two algorithms in LINAC system.
Okay, thank you very much.
Thank you.
The exposition will be continued by Dr. Zindler. He is radiation oncologist at the Holland Proton Therapy Center.
Yes, and also working in Haagland Medisch Center. I would like to congratulate the candidate for his very nice work, and also the Maastricht team and the skull-base group for this nice thesis. It's a pleasure to read, and it's since 3 years we have proton therapy available in the Netherlands. So this is a very relevant thesis for our patients. I would like to start my questions with one of your propositions, is the sixth one. And there's no safe dose of radiation, even small amounts do harm. That's of course bad news for us. But fortunately at page 82, you say induction of second tumors is negligible. So maybe with modern techniques, it's not so dangerous anymore. And I was wondering, is there a safe type of surgery? And so that's my question. And we use also in vestibular schwannoma, actually because of the safety of radiotherapy, we often prefer radiotherapy above surgery. So I was wondering if you would like to change your proposition, or if you really would like to keep it this way.
Thanks for your question, and congrats. No, I think I will stick to my proposition, because I think nobody can say that radiation can be excluded from the scene of resulted radiation side effects. Nobody can guarantee that even small amount of radiation will not cause damage to the healthy tissue. So I think I will stick to my proposition.
Okay, thank you. My second questions are for chapter 2 and 3, and it's regarding the proton therapy for the chordomas. Yeah, so you truly say, to my opinion, that toxicity with the proton therapy is high, what you see. And I was wondering, is it the proton therapy, and what is the contribution, for example, of the surgery in the side effects? And are modern techniques that we nowadays use, such as IMPT, would you expect that what we nowadays do with proton therapy is better than what they did in the old days with passive scattering?
Yeah, I agree with the modern technology might bring better preservation for the normal tissue and lower the number of side effects after radiation therapy. But most of our patients were treated maybe before 10 years and about 10 years. So maybe at that time, the type of therapy wasn't improved nowadays. But also I can say that even the relative radiological effectiveness of proton therapy and the assumption of 1.1 of linear energy transfer of proton therapy is still debatable. So it might be the cause of these radiation side effects. So, and it is controversial that the assumption of 1.1 of RBE of proton therapy might be more. It might reach 1.1, especially at the distance or the distance range of proton therapy. So yes, the modern technology might bring better results of lowering the radiation side effects, and we hope to see that.
Yes, I agree with you. We better contour the organs at risk, and we can use, because of robotic couches, less uncertainty margins. So there's less high dose in the organs at risk now. So we hope, for example, to avoid temporal lobe necrosis. So I agree with that. And with, for example, ARC techniques in the future, we might even put the RBE effects in the center of the target volume. So there's a lot of work to be done. But still, to comment on that, would you state that we should treat a subset of patients with chordoma with photons instead of protons? And could you comment on the differences in the high dose, intermediate, and low dose between protons and photons? So how would you select then subset of patients for photons? And do you expect better results in the high, intermediate, and low dose?
Yes, well, yeah, some patients, I came across some studies that they reported the feasibility of using gamma knife, high dose of gamma knife with the chordoma patients. And they actually got similar results to those reported after proton therapy. So maybe using proton therapy is selection the patient, how to select patient for photon irradiation for chordoma patient and proton therapy is actually maybe depends on different factors, such as maybe the availability of or the location of the tumor itself. So it might be like if we use lower dose of photon irradiation, so it might near to the sensitive structures, it might like expose the tumor or the healthy tissue or surrounding sensitive structures to unnecessarily dose. So it's better to use proton therapy to try to spare these sensitive structures.
Yeah, so I agree with you, especially when you have a tumor against the chiasm. Sometimes you're better off with photons, but it's a very small subset of patients, because you lose sometimes in the high dose and you win in the intermediate and low dose. So could you comment on the biggest problem with gamma knife?
Biggest problem of gamma knife?
Yeah, biggest limitation of the use of gamma knife?
I'm not sure how to answer this question actually. So I would say I don't know how to answer.
Gamma knife is just a brand for photons. You can do it with CyberKnife, with lots of other machines. The biggest limitation is that you only can use one fraction usually because of an invasive frame. But we can reach same treatment plan quality with other types of machines, and also same clinical results that has been published extensively. So especially in your vestibular schwannoma patients, could you think of a strategy with another machine than gamma knife to even further improve your results with the combination of surgery and radiosurgery?
Yeah, of course, we can use Linac or CyberKnife in fractionations. Yeah. So it
exactly. It's the fractionated approach. So I think it's
5 and 5. Yes.
In 5 or maybe even in 30 or
3. Yes. Yes. So I think we can use Linac.
So if you would do these studies again, why would you not include all other types of radiosurgery machines?
Actually, it will be out of the scope of my thesis. So we focused on a certain type of patients, which used one fraction radiation therapy of gamma knife after a planned partial section. So maybe in the future research, maybe we can extend our scope to do another research with Linac and compare the two modalities.
Yeah, I certainly recommend that. That were my questions. Thank you.
Okay, the opposition will be continued by Professor Van Zandbrink, Professor in Spinal Neurosurgery at Maastricht University Medical Center.
Thank you, Mr. Prorector. Of course, I want to congratulate you with your work and incorporate in this congratulations the promotion team, family, and friends. I want to discuss with you chapter 3. And I read this chapter, and you are looking at recurrence patterns in Chordoma patients. And you gathered 30 patients during a long time. And from these 30 patients, 15 had recurrences. Yes. And you only studied 7. Can you explain to me why you didn't incorporate those 8 others with recurrences to investigate the recurrence pattern?
Highly esteemed opponent. Thank you for your compliments and question. Yeah, because we focused on the efficacy and safety of proton therapy, and the other patients who had recurrence were treated by other modalities. So our focus was on the proton therapy efficacy and safety. So that's why we were limited by the number of the patients, 7 patients.
7 patients is a small number.
Yeah, but when you compare by the recurrence is very rare disease. I mean, the chordoma, very rare disease, so it affects 1 in a million.
So it is worthwhile to double your number in investigation, or isn't it? Or
might be in the future with the presence of proton therapy modality in Maastricht clinic, because all of our patients were treated abroad. So none of them was treated in Maastricht. So now with the availability of proton centers here in the Netherlands, we can gather more data.
Is there a big difference in treatment strategies between those 2 groups? Then you already said in a former answer that there is no difference between gamma knife therapy and proton beam therapy, also for chordomas.
In the presence of high doses, sometimes it's difficult to prove the superiority of one modality than the other modality, because most of this is aggressive tumor. So sometimes it's difficult to have like a concrete understanding of our results. It's all expectation, and we analyze the data, and based on these images, we came with the results and the best understanding.
Mm-hmm. Okay, thank you. Can you again elaborate on the results you found on the dissemination pattern after surgery? Where did you find the most recurrences?
Most of the recurrences were found in the surgical pathway. So one of the findings reinforced this result. When we found like a resected recurrent chordoma, later we will find like a multiple recurrence at the same place. So this actually confirmed this result. So surgery can spread the tumor cells out of the primary location of the chordoma.
Okay. So all these patients were irradiated on the tumor bed, I think.
Yes.
Yeah. Finding these results now, would you change your irradiation strategy?
Yeah. Deciding which radiation strategy is based on the patient characteristics. So the tumor location, the size, and also whether this chordoma being treated before, resected or not resected, if the patient is like still young and not young. So different factors can yes.
So you discuss with Professor Timmel. He is doing the surgery, and he explains to you the pathway towards the surgery. Would you change or incorporate his pathway in your radiation strategy?
This is a very difficult task, because also we want to avoid radiation necrosis. Radiation necrosis is similar to the recurrence. So you will end up with something that you don't know. You will radiate a place or an area which you expect that there will be a recurrence in this place, but definitely or not definitely, most probably will cause recurrence. I mean, necrosis in this area.
But necrosis in the brain or in the subcutaneous tissue, then I understood the most recurrences in the pathway are in the soft tissue. So would you expect necrosis of the soft tissue?
Yeah.
Also?
Yes.
Is it as sensitive as the brain for irradiation?
Say that again?
Is it equally sensitive, muscles, skin, to radiation than the brain?
The brain is very sensitive to necrosis. And also, I think it's also differ based on the type of surgery. So some is like open surgery. There will be like surgical, cavity is bigger than the endoscopic surgery. So I think also based on the surgery type approach.
Okay. Then when you combine all the results now, do you have an advice for me treating chordoma? And just for also in the sequence of treatments, just first surgery, and when do you advise to irradiate? Immediate after the surgery or after recurrence and after the second surgery? Then those which you investigated, 5 of them were irradiated after the second surgery. Can you make a compilation of all these results and give me an advice how to treat a chordoma?
Yeah, again, it's also depends on the patient situation and characteristics. Some patient will require only biopsy and radiation. That's enough, and it will work with him. Some patients, you can resect the tumor. So the resectability of the tumor itself, you can reach the place of the tumor and you can resect it. Why not resect it and wait? And if you cannot resect it, maybe radiation therapy will be more effective in this case.
Okay, so it is a multidisciplinary approach.
Yeah,
still.
Thank
you. I will give the word back to the pro-rector. Thank you for your answers.
The opposition will now be continued by Professor Mess. He is professor in clinical neurophysiology at Maastricht University Medical Center.
Well, thank you. First of all, I would like to congratulate you and your team of supervisors with this thesis. And it allowed me a peek into the wondrous world of radiology and radiotherapy. You have a quite fancy title of your thesis. And there is especially one word that intrigued me, and that is nuance. What does it mean? What is nuance? What do you think in general? Very short answer, please. Very short.
Highly esteemed opponent, thanks for your congrats and questions. Nuances means like subtle differences. So sometimes,
yeah, that's right.
Like
and how does this refer to your thesis?
Yeah, I can refer to the finding after proton therapy. So sometimes you are confused if this recurrent chordoma or radiation necrosis. So this is one of the things that can reflect to that title.
Okay, so if you use such a word in a title, as a reader, you would expect that this refers to more than just one topic. So let's go, for example, to chapter 5, and it has already been discussed. So that is your Schwannoma group, 25 patients. And in the end, all went well, at least in terms of facial nerve function. So what is the nuance here? Is there any nuance in chapter 5?
Maybe can reflect to the function of the facial nerve itself. So, and also the complications after irradiating the remaining tumor.
Yeah.
So if there is
But the point is, and you showed in your very nice presentation, you showed it once again, you had 100% perfect result. In all patients, the functional nerve did very well. So I was a little bit wondering, what is the subtle difference? So the nuance, it is just perfect all the time, isn't it?
It might be from in this chapter. It's not relevant.
Okay.
But other chapters, I assume it's relevant.
Okay.
Like the differences in low doses.
Okay, a little bit a more serious question here is: have you considered not to use just one regimen, but to set up a study where you compare 2 regimens, so to really get an idea which regimen is the best?
for vestibular schwannoma?
Yes.
No, actually, do you mean that in this study, if we use two strategies to treat the patients?
Yeah, that
and
would
which
be a
one is the
usual
best?
way in science to have a prospective randomized trial where you compare two regimens.
Conducting prospective studies, and especially in large vestibular schwannoma, is quite challenging.
Mm-hmm.
None of the patient who has like a large vestibular schwannoma will wait and will accept to be enrolled in prospective studies. So due to the nature of the disease, it's sometimes difficult to conduct a prospective study.
Yeah, I fully understand that. So let's go on to chapter 6. And so you did a study in a single subject, and that, I was really fascinated by that. Just one person. How can you be sure that your results can be replicated in another individual?
Yeah, I agree with you that one participant is not enough to use this sequence in the clinical practice. But the aim of this chapter was like to prove the concept that this sequence can work. And in the future, we are aiming to add more healthy subjects and maybe use it in a multi-synthetic study, maybe from here, Netherlands, and maybe Saudi Arabia.
Okay.
We don't know, but this is one of our aim to extend the number of samples.
Well, this sounds like a good answer, or let's say socially fully acceptable. But do you think that this makes really sense? Why bother about the facial nerve? Is there maybe another way to check whether the facial nerve is okay?
During surgery?
For example?
Yeah, EMG, for example, electromyography, can help the clinician or the physician to also probe the facial nerve and to avoid injuring the facial nerve during surgery. But why not using other modality or other tool to help the surgeon to save the function of the facial nerve during surgery?
I think we are both heavily biased here because I'm a neurophysiologist, so I go for the monitoring. And maybe the patient might go for the monitoring too, but because in the end, it is the function of a structure, not its appearance on an image, that really does matter to the patient. So, but this, of course, is my belief, and it is the luxury that I have the final word here. And thank you for your answers, and I will give back the word to the prorector.
Thank you.
The opposition will now be continued by Dr. Abdul Rahman. He is a radiologic technology consultant at the King Fahad Hospital, Daman, Saudi Arabia.
Thank you very much, Mr. Prorector. Dear candidate, I have read your thesis with a great pleasure, and I would like to congratulate you and your supervisory team. I will continue for the question from Professor Mess that for chapter 6, you have only one subject, and also you have recommended, or you have one protocol that diffusion weighted imaging, while there are different protocols to achieve the same result, such as 3D T1 spoiled gradient echo or 3D fast spin echo, or also the post-gadolinium T1 weighted. Because those three sequences is more practical with the basofiscal due to the high artifact from the basofiscal. So why you did not compare your diffusion weighted with another sequences?
Esteemed opponent, thanks for your question and congrats. So if I understand you correctly, you are suggesting to compare the diffusion weighted imaging results with the high resolution MRI, T2 MRI. As we described in that chapter, that the 3D or the 3D high resolution T2 MRI can be easily distracted by the morphology of the tumor. So it's found, the diffusion weighted imaging found more practical during surgery, or to find the facial nerve around the tumor during surgery or before surgery, So the other type of imaging will not be affected much by the tumor morphology.
Thank you. The second question is, how did you validate the proposed protocol, the optimal one? How do you validate it? Because
we validated our choice by three things. First, visually. So the selected or the selected sequence represent the best image results for the facial nerve in terms of the shape of the facial nerve and the vestibulocochlear nerve, and also the location where we can expect to see the facial nerve in the brain. The internal auditory canal until the exit route of the facial nerve itself. And also we validated our choice by giving one of the expert neurosurgeon the B0 images, which is basically a lower resolution, low resolution T2 images. We gave them these images blindly without knowing the results of our tractography, and we asked him to draw over where he can see the facial nerve in these images. And actually he drew the over the facial nerve, and he selected the same sequence that resulted in the best imaging of the facial nerve. So his results agreed with our results without knowing the tractography. This is second validation. And the third validation by the quantitative measures. So the selected sequence represent the best, reasonable quantitative measures in terms of fractional anisotropy and radial diffusivity and axial diffusivity. So, and it agreed with what has been published in the literature. So we used these three steps to validate our choice.
Okay, thank you very much. And back to the proactive.
Okay, we still have a few more minutes, so we will try to continue the opposition. I would like to invite Dr. Paiva Fonseca. He might have an additional discussion or question to the candidate.
So I would like to go back then to those calculations. So if you compare the proton therapy and the photon therapy, what would be your preference considering price limitations and also the outcome of the patient?
So you are asking about proton therapy in comparison with the photon irradiation in specific type of tumor or just in general?
So in the beta school tumors that you evaluated, and if you have a preference for the modality, or do you think you can have similar results with photons and protons?
I would go with the photons because it is known that proton therapy will cost more. And if it is known from the literature that both can result in the same control rate and the toxicity results also the same, we can go for photon irradiation.
But do you expect it to have less toxicity with protons or photons?
Based on the literature, there is no clear cut that proton therapy can result in lower toxicities. So we can't see any difference between the two types of tumors. Maybe in pediatrics, it is more relevant because they are still young and maybe to spare their sensitive structures better than photon irradiation. So we would go for proton therapy. Yes, if he's
You may finalize your answer or not.
He's satisfied with that.
It's okay. Okay, then, Mr. Alahmari, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense, and I request that you and your company await the results of our deliberations and our return in this room. Mr. Alahmari, the degree committee here present has assessed the quality of your thesis and of your defense. And in view of its positive verdict and taken into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Timmel is authorized to confer upon this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Mohammed Ali Alahmari, the degree of doctor, and grant you all rights attached by custom and law. As evidence of this, I will present you the degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university. The laudatio. I need to take the right paper. Dear Dr. Alahmari, dear Mohammed, congratulations. Today, you have reached the top of the highest academic mountain, called the PhD. This climb was a tough one and deserves a reflection. When we successfully interviewed you for a PhD position in our department 6 years ago, your motivation to develop yourself was very strong and motivated us to invite you definitely. When you arrived to our group, you needed time to adapt to the city and culture. Finding a house, registering your children to the international school, and understanding the way that we live and do research were your first challenges. Another challenge was your supervisory team. We started with Professor Stokroos, ENT surgeon, Professor Hovenbeke, neurosurgeon, and me. But after 1 year, Professor Stokroos left us. And 1 year later, Professor Hovenbeke left us. So at some point, we were just two of us working. In this period, you learned that most of the challenges, problems, can be solved. We had to find new, suitable supervisors. And we were lucky, we found Dr. Ekers and Professor Verhagen, who contributed to your development as a scientist. On your climb to the top of the academic mountain, you have acquired new skills. You had to acquire new skills. These new skills were necessary to continue the climb. Methodology, statistics, principles of systematic reviews, MR neuroanatomy, MR volumetry, and radiation safety principles. Mohammed, the climb was tough, but you were tough too. I hope that you can take some of our science and culture back to your home and continue scientific research and inspire people around you. I wish you and your beloved ones a great future.
Dear Dr. Alahmari, also on behalf of the Board of Deans, I congratulate you with the honor you have acquired. I would also include your family and your relatives, your loved ones, in this congratulation. Before I end up, I have a few logistic things. One is that I invite your company to leave this room when I formally finalize. You leave this room and go to the reception office, and the members of the opposition, of the online opposition, to stay, which allows then them to congratulate the candidate, the new doctor. So with having said that, I finalize this session. Rise.